This is Dr. Edward Gaber. I'm a board-certified internal medicine doctor and have a solo private practice. I'm also a hospitalist 14 nights a month. I've been in practice 52 years, so I feel qualified to talk about chest pain as I believe I've seen about all the different causes of chest pain over the years. I want to discuss mainly the initial evaluation of chest pain in patients. Chest pain can be very challenging. As a medical student one day, I was told by my medical school professor that human communication is the most dangerous thing in the world. Taking an accurate history from patients can be very challenging, and errors occur if you jump to conclusions or put words in the patient's mouth by asking leading questions, and of course by not doing a complete physical. However, one of the joys of being a physician is the Sherlock Holmes aspect of figuring out the diagnosis from many different, often conflicting clues. Another fun part is finding the oddball or esoteric diagnosis. For example, one day I saw a young executive in my office. He was complaining of severe chest pain. As he took off his long-sleeve white shirt to be examined, I noticed a puss caterpillar fell out. How about that for a weird diagnosis that day of chest pain? Actually, statistics show that only about 3% of patients who come to a medical office with chest pain have chest pain from coronary artery disease at that time. But that is no reason to ignore the most minor chest pain. When I first went into practice in 1975, a 41-year-old smoker, patient new to my practice, told me he had sharp, localized, brief chest pain as his commercial flight was landing in the New Orleans airport a few weeks prior. He had had no further chest pain since that time, and I did an EKG which looked very, very normal. I didn't have a treadmill in my office at that time, so I got him scheduled for a stress test at the hospital 2 days later. Unfortunately, that night, he had a major heart attack. I've taken even minor chest pain since that time very seriously, realizing that even slight chest pain can be just a shot across the bow, warning us that something major might occur. However, the vast majority of localized, sharp chest pain is musculoskeletal, with usually a dime-sized area of pain and tenderness at the costochondral junction, where the ribs meet the breastbone. This is called costochondritis. It can also be from a tender xiphoid bone, the little prominence of bone you can feel at the very bottom of the sternum. It can be pain at the edge of the lower ribs, revealed by hooking fingers below the lower ribs and pulling upwards. It can be radicular pain coming around from the back, diagnosed by noticing marked tenderness when pressing on the thoracic spine facets, 2 inches to the side of the spine. This is called facet syndrome and causes nerve irritation that can travel around from the back to the front of the chest. With musculoskeletal chest pain, the patient may have been lifting grandchildren, twisting and bending a lot, or coughing vigorously recently, or had some trauma recently to the chest wall or shoulder, perhaps when falling down. Also, don't ignore the possibility of domestic violence or elder abuse. A rib fracture can cause persistent localized chest pain and tenderness. The rib fracture may not be seen on rib x-rays for 10 days. Cervical radiculopathy from pinched nerves in the back of the neck can cause upper chest pain without neck pain or pain down the arm or numbness down the arm. The Hoffman's reflex or Sperling test seen on YouTube can be very helpful in diagnosing pinched nerves in the neck. Fibromyalgia patients can have anterior chest pain. I note tender trigger points in the trapezius muscles between the neck and the shoulders. Herpes zoster can cause radicular chest pain. I look for a radicular vesicular rash coming around from the back in a dermatome fashion, or just a few early vesicles on the side or back of the chest wall. But let's talk about cardiovascular causes of chest pain. Angina is often gradual in onset. It can occur at rest or on exertion, and usually lasts anywhere from 5 to 30 minutes. Unless, of course, it has progressed to a true heart attack. It can be relieved by nitroglycerin, but just because it is relieved by nitroglycerin does not mean it is cardiac pain, as esophagus spasms can be relieved by nitroglycerin as well. A heart attack can be accompanied by sweating, nausea, faintness, palpitations, or none of these symptoms. The pain from angina or heart attack is often across the front of the chest, mid-chest, left-sided, and occasionally right-sided, and it may radiate to the front of the neck or back of the neck, to the jaw, to the shoulders, or the inner arms. I saw a patient whose angina only manifests as severe posterior neck pain on exertion and no chest pain. If a patient's older, has a past or present smoking history, has a first-degree relative, non-smoker with coronary disease, has a history of hypertension, cholesterol problems, or especially diabetes, that patient is strongly suspect for coronary disease, also called acute coronary syndrome. Acute coronary syndrome is one of three things. Number one, unstable angina, or number two, an NSTEMI, which is a non-ST segment elevation myocardial infarction, or number three, a STEMI, which is an ST segment elevation myocardial infarction. Serial EKGs and cardiac enzymes such as troponins and CKMBs can help decide the diagnosis. But remember, biotin vitamins can artificially lower cardiac troponin levels and cause confusion, and also there are many non-cardiac causes of elevated troponin levels. I always remember that older patients, female patients, diabetics with neuropathy, may present with shortness of breath on exertion, or weakness on exertion, or fatigue or faintness on exertion, and no exertional chest pain despite having severe coronary disease. If a patient's been abusing amphetamines, cocaine, or even marijuana, which can cause coronary spasm, we will strongly suspect coronary disease chest pain. I saw a 28-year-old patient with a heart attack after smoking marijuana. Young age should not cause a physician to negate the diagnosis of coronary disease. Over the years, I've seen several women in their mid-30s with heart attacks. Usually, they're smokers. I saw a 13-year-old with exertional angina. She had congenital absence of a coronary artery. There are also patients with Prince-Metal angina with intermittent, unprovoked coronary artery spasm. ST segment elevation changes on EKG are seen on EKG or event monitors at the time of the chest pain. Catheter purification of a coronary artery during coronary angiograms demonstrate the artery spasms. Patients with pulmonary hypertension can have chest pain. Patients with aortic valve stenosis or mitral valve stenosis can have chest pain on exertion. Patients with mitral valve prolapse occasionally complain of sharp transient chest pains, and patients with Takotsubo's cardiomyopathy may have chest pain with anxiety. Patients with run-of-the-mill congestive heart failure may often complain of chest pain, but they really mean chest tightness when they get short of breath. Pericarditis with or without tamponade, with fluid around the heart, and occasionally with distended neck veins or pulsus paradoxicus, often have sharp pleuritic chest pain, improved with leaning forward. Coxsackie virus, autoimmune disease, kidney failure with uremia, and rarely cancer may cause pericarditis, and colchicine may help viral pericarditis pain. Myocarditis, an inflammation of the heart muscle itself, can cause chest pain and even elevated troponin levels. Aortic artery dissection. A patient of mine called me at 5 p.m. one day many years ago. He told me He had just been discharged from the coronary care unit of a rural hospital after several days of observation for severe chest pain. On discharge, they told him there was nothing wrong with his heart. He was still having chest pain, so he called me to ask my advice. I actually remembered that he had an aortic insufficiency murmur and asked him if his chest pain went straight through to the back, which can occur with aortic dissection. It did. I told him I needed to admit him immediately to rule out aortic dissection. That night he was successfully operated on for a dissecting ascending aortic aneurysm, John Ritter's disease. He sent me many new patients from up the river for many years after that. Pulmonary causes of chest pain. Asthma patients often complain of chest pain, but they really mean tightness. On auscultation, wheezing can be heard, but often wheezing is not heard, but very diminished breath sounds are noted. Pleurisy. Pleurisy is pain from the outer lining of the lungs, and there's pain when taking even small breaths. Pleurisy can be viral or autoimmune or bacterial pneumonia above it, or rarely secondary to lung cancer with pleural involvement. The chest pain is often severe, as the outer lining of the lung is as sensitive as the eye, and that's why it's called devil's grip. It also is often caused by the Coxsackie virus. Pulmonary emboli. Pulmonary emboli can be life-threatening. There's often pleuritic chest pain, low oxygen levels, and rapid heart rate, but not necessarily any of these. Sudden syncope or fainting can be a pulmonary embolus. Deep vein thrombosis of a leg can sometimes be found as the cause of the pulmonary embolus, but more often than not, it is not present. Pulmonary emboli can happen after a long car trip or a long plane trip, as the low barometric pressure inside the plane predisposes one to deep vein thrombosis, especially if the flight is over 8 hours long. A pulmonary embolus can occur after straining at stool. Obesity, patients over 65, patients with congestive heart failure or cancer, patients on birth control pills or estrogen postmenopausally, or pregnant patients are predisposed to pulmonary emboli. Post-op patients, especially orthopedic surgery patients, are predisposed. Patients with recent, even minor trauma to the legs, and patients with coagulopathies such as antiphospholipid syndrome, Leiden factor, factor 2 mutation, antithrombin 3 deficiency, protein C, protein S deficiency, or family history coagulation disorders are predisposed. The rare patient with paroxysmal nocturnal hemoglobinuria, which I've yet to see, the polycythemia vera patient, or a patient with essential thrombocytosis, is predisposed. A CT of the chest with contrast is the best way to find pulmonary emboli, but acute or chronic kidney disease or an iodine allergy may not allow us to use iodinated contrast, and a nuclear VQ scan has to be done the next day, but the VQ scan may be worthless if the patient has pulmonary infiltrates. If the patient has pulmonary infiltrates and kidney disease, and both these conditions prevent the absolute diagnosis of pulmonary emboli, empiric therapy with heparin or Lovenox is indicated. Thrombolytic therapy is typically reserved for patients with massive pulmonary emboli resulting in hemodynamic instability with hypotension, with a systolic blood pressure less than 90 or a decrease in systolic blood pressure greater than 40 from baseline, or respiratory distress with oxygen saturations less than 90% on 4 liters a minute nasal O2, or a respiratory rate greater than 40. Clot extraction is now done at our institution using the same criteria. Spontaneous pneumothorax. Spontaneous pneumothorax is when the lung blows out with sudden shortness of breath and pleuritic chest pain, especially if there's tension pneumothorax, which can occur with hypotension and rapid heart beating. Acute chest syndrome with infiltrates from sickle cell disease is another cause of chest pain. Anxiety, panic attacks, hyperventilation syndrome causes chest pain, but we cannot ignore the fact that there may be coexisting coronary artery disease causing chest pain. Gastrointestinal causes of chest pain. Now, many dead on arrival patients in the emergency room told their wives they had been having indigestion. But there are many causes of chest pain emanating from the GI tract. One is esophagitis, secondary to hiatal hernia and gastroesophageal reflux. This can cause severe pain from esophageal spasm, also referred to as nutcracker esophagus because it hurts so bad. Boerhaave syndrome with esophageal perforation causing excruciating chest pain from the perforation of the esophagus with forceful vomiting can cause terrific chest pain, and Mallory-Weiss syndrome of the esophagus with forceful vomiting results in esophageal tearing and bloody vomitus. Esophageal food bolus obstruction causes severe chest pain with excessive drooling because of the inability to swallow saliva and suprasalivation. Esophagitis itself can be caused from fungus, from food allergies causing eosinophilic esophagitis, from HIV-related cytomegalovirus. Esophageal ulcers, erosive esophagitis, Barrett's esophagitis, and esophageal cancer with it or without obstruction can cause chest pain. Gallbladder disease can cause chest pain. I saw a new patient in my office several years ago. She had suffered with intermittent chest pain for 10 years. On physical exam, she had a positive Murphy sign with tenderness on palpation of the right upper quadrant of the abdomen when she took a deep breath, suggesting to me she had gallbladder disease. After her cholecystectomy, she had no further chest pain. Chronic low-grade cholecystitis can cause chest pain without right upper quadrant pain. I hope this discussion has been helpful. Please do not ignore your own chest pain. See your physician as soon as possible. Have someone bring you to the emergency room if you have chest pain. Never, never assume your chest pain is indigestion, and always get a professional opinion if you have chest pain. Do not think you can rely on this talk to self-diagnose your chest pain.